Assalamu alaikum and good morning, everyone. My name is Dr. Kashif Sajjad. I am a consultant physician in palliative medicine at Shaukat Khanum, Peshawar. It is my great honor to welcome you all for our 20th Palliative Medicine Shaukat Khanum Symposium session. So I'm joined by Dr. Harun Hafiz, who is my co-moderator. He's a senior consultant in palliative medicine since 2008 at Shaukat Khanum Hospital, Lahore. He has had a key role in establishing palliative care services at Shaukat Khanum Trust. He's the Director of Quality and Patient Safety Department and Associate Global Director for South Asia, appointed by Royal College of Physicians, London. So, as we all know, that COVID-19 pandemic has stranded all the healthcare systems across the globe. These 2 years have been really challenging. Like every other specialty, we as a palliative care community faced numerous challenges too. In this session, we are going to talk about some of those challenges with a special focus on communication-related scenarios. So without any further ado, I'll take the opportunity of introducing our first guest speaker, who is Dr. Fiona Rawlinson. Dr. Fiona Rawlinson is a consultant physician in palliative medicine at Cardiff University. She's a program director for Masters and Diploma in Palliative Medicine at Cardiff University. She's been actively involved in developing curricula for Masters and Diploma in Palliative Medicine. She has been a great supporter of palliative care education and development in sub-Saharan Africa and South Asia. One of her key areas of interest is use of technology in enhancing the delivery of education. So welcome, Fiona. The first topic of the talk is the collusion, an issue encountered in patient-family meetings.
Hello, everybody. I'm Fiona Rawlinson. I'm absolutely delighted and honoured to be part of the conference this year in 2021. I'm a consultant in palliative medicine and I'm the programme director for the Master's course from Cardiff University. This session is about really highlighting some of the practical issues and things to think about when encountering collusion, when talking with patients and their families. I'm aware that I'm presenting this from a very Western perspective because that's where my clinical practice is. But I think some of the issues around understanding how collusion arises will be helpful wherever one works in the world. And perhaps some of the thinking and the questions and the reflections may also be helpful. So we're going to explore the meaning and the impact of collusion, and then we're going to outline possible management options. But I think first it's important to just be clear what it is. And collusion is, as defined by the Oxford English Dictionary, a secret agreement between or cooperation between 2 or more people who are trying to deceive. So for us in healthcare, and particularly in palliative care, it's very often around information for diagnosis, for changing disease status, for treatment intent changing from curative to palliative, recurrence, etc. It can also go the other way, though, in fact. Sometimes patients and their families will also collude with each other against the healthcare profession, perhaps for fear of stigma or discrimination. So collusion actually is much broader than simply a family trying to protect their loved one. And why does this happen? There is usually a reason behind collusion, and most often it's fear of distress for the person. It might be fear for actually what might happen. It might be that families can't manage to think easily about the fact that their loved one is going to die. It's usually wanting to protect that person. It arises for love of the person with the condition. They don't want to see more distress. They might have had a difficult experience in hospital or around communication. Very often, if bad news is broken badly, with difficult communication, then any subsequent consultation will be affected by that. And they want to protect their loved one from difficult or harsh conversations. Sometimes it can be around control. If a family situation has had a very controlling or dominant family member, that also will impact on how that dominant family member wants information to be shared. So are there conspiracies? around the patient, a conspiracy of love, a conspiracy of control? Is there what's called a recovery plot, where the family and the healthcare professional are talking treatment? They're talking admission to hospital, surgery, radiotherapy, chemotherapy, if it's cancer, and everybody's in the zone talking about positive things. The healthcare professionals talking about things they feel very comfortable with, they know a lot about. But actually, what the patient wants to know is, am I dying? And nobody's talking about that. And is my perception of how I'm feeling completely different to the experts around me? So it's a mismatch. There's a big mismatch can occur in collusion, which can be really frightening for the patient. And in us as healthcare professionals, do we buy into collusion? Do we add to the collusion? Is that for fear of causing distress? For fear of handling the emotional response to the information? Yes, maybe. Does it a lack of confidence about managing people's responses? Yes, maybe. Is it actually the fear of being perceived a failure, whether that is culturally where we are working, or whether it's just that we have strived for this person and actually now the treatment options are running out? And what will people think? What will happen to my reputation? So actually, us as healthcare professionals can also add in to the collusion. If it's too difficult to break bad news or to change the situation, it's easy to collude with the family and not go that one step for the patient. But certainly in Western cultures, where there is individual autonomy, the patient is our priority. We are unwise to go against the family or against what the carers, to not listen to carers. That is also not professional, not acceptable, but our duty of care in Western cultures is to that patient. But going back to collusion, the other thing that so often we forget is that it's ever changing. It can be a broad collusion. It is the cultural norm to collude, for families to collude around a patient. And whichever part of the world you're in, you will come across groups of patients from different cultures to that of the country. Is it more focused? Are there different elements of collusion within a family? So family dynamics. One brother doesn't talk to another brother. One sister won't talk to her husband's partner. Whatever it is, there may be family dynamics. It can be partial. There can be some bits of information that are okay to share, but not others, or complete. It can change according to a phase of an illness. Early on in an illness with a terminal diagnosis, so an illness where actually death is going to happen sooner than otherwise thought. Early on, there may be moments where the patient feels robust enough to handle the information, and then there may be times when they don't. Family dynamics can change between appointments. You can have appointments where the wall of collusion around the patient is thick, and you're exploring and thinking to yourself, I'm not going to get anywhere. And then 2 weeks later at the next meeting, suddenly something's changed. You have no control. We have no control as healthcare professionals as to what families do between meetings. Sometimes they can change. So every meeting, we have to approach it with a clean sheet of paper. I think that's what makes palliative care communication so rich and so varied and so rewarding, but you really have to keep on your toes. So it comes in different forms. Collusion comes in different forms, intensity, and is often not absolute. So what are we talking about as healthcare professionals? To tell or not to tell? What will happen if I am honest about this situation? If it's a breaking bad news situation, there will be an emotional response, which might include anger, it might include crying, it might include silence, it might include depression, it might include despair. There will be a response. But if you think about bad news, breaking bad news, think about that in terms of loss. It's a loss of the original game plan, the original health-focused game plan for life, that death was going to happen sometime in the future. It's a loss to somebody of their original view of the future. But think about grief reactions. loss reactions. There is a natural collection of emotional responses, including all of those things, which actually the patient with time works through. And I'm not falling into the trap of saying time makes things any easier. I'm not sure it does. What time does do, though, is that it allows people to get a bit more practice at handling a situation that has become different to the one that they thought of. So there are the difficult reactions to bad news. However, there are also the other emotional reactions to honesty, which is being honest with emotions, talking frankly with families, sorting out unfinished business, future plans, making wills, telling people you've loved them. But if you don't tell people, then they're not going to get a chance to do that. Ira Byock, who works in the States, and did some fantastic work with HIV and AIDS gentlemen in the late 80s, early 90s, in the middle of the HIV/AIDS crisis there, before the antiretroviral treatments came on. And he did wonderful interviews with very, very able communicators. And the themes running through those interviews were 5, which was, as death approaches, people were trying to say things like, please forgive me, or I'm sorry, I forgive you, I love you, thank you, and goodbye. And what that cohort of people were also saying is, don't leave it till now. Live your life attending to, thank you, I love you, I'm sorry, I forgive you. And that's developed into this concept of the 4 things that matter most. And I think that's the thing about palliative care, isn't it? Actually, palliative care is about living. What do we learn from our patients and the families we look after? We learn about things that are important at the end of life, but actually, if you are proactive, you think, actually, this is in fact about living, how to get the most out of every minute of every day, because you don't know when that last breath is going to come. So, reactions to bad news can be 2 things. There can be the emotional, difficult reactions, which will work themselves through, but also then there can be some really important positive reactions to bad news. And fundamentally, what we're talking about managing collusion is trust. So if a family has colluded with healthcare professionals and has not been talking to the patient, and the patient knows this, how is the patient going to trust the family to look after them? How will they know that the family will do what they would prefer, would manage to give them symptom control, would disport their possessions to where they want them to go? If healthcare professionals collude with families against the patient, how will that patient know that you're going to give good pain control, attend to symptom control, ask colleagues to see them if that's necessary? So the big thing about collusion is that it destroys trust. And once trust has gone, it's really difficult to build up again. And you probably know this from other spheres of life. Trust is a crucial element of communication and of relationships. And as we've said, managing collusion is important because it enables people to complete life tasks, to complete things that they really want to get done. In this incarnation of us on this earth, we are here once. We might come back in a different incarnation, of course, but actually there are things that people might want to do in this version of life that they're living. And to not enable them to do so does not seem the right course of action. So that's what it is. You know it, you'll have seen it, you'll have encountered it. It usually comes up in probably most days at some sort of aspect of a day. How do we manage it? I think acknowledging that it's there. Terribly useful phrase, what am I hearing, what am I seeing? I can hear that you're really concerned about me talking to your father. I can see that you're really upset at the thought that I need to talk to your mother later on today. So acknowledge what's happening, explore it and validate it. I can understand where you're coming from. Beware of that phrase, I know how you feel. That's not a good phrase to use because you're not the other person, but you can show understanding. I can hear that you're concerned because you're concerned that your mother is going to get very distressed. So explore it, validate it, but also talk about the potential costs of collusion. The trouble with withholding information is that actually your mother may not then trust you, or particularly me, to be able to look after her in that last bit of life. That might make her very frightened and very distressed. So establishing the potential costs, agreeing the next steps. Sometimes that can be bringing the family with you. If it's family versus patient, say, why don't you come with me when I go and see your mum? And then you can hear how I talk with her. And that can sometimes really make a difference. I know coronavirus has made that much more difficult, but with iPads, with smartphones, you can still do it. And particularly if the fear from the family of distress has arisen from a difficult Breaking Bad news consultation when they weren't there. They've only got that person's, the patient's perception of what happened. Really useful to bring the family along with you. But really important to stay detached and objective. You can explore the knowledge with the patient, ask them what they know, ask them what they would want to know. And again, think if you're the person who's doing the Breaking Bad news for a patient at the start of your palliative care relationship with them, that's a really good time to establish with patient and family, look, as things change, how are we going to do this? You know, will you want your father or your brother to always be with you? You know, do you want me to be honest with you each time, or you can establish that sort of relationship, but you are that bridge between the patient and the family. But as we said, things change, so you need to keep checking it for every time you do a consultation. But time invested now, when you can see collusion is happening, time invested is incredibly important and will lead to better outcomes in the end. Toolkits of communication skills. We've got a separate session about this, so I'm not going to spend too much time on this now, but one of the really useful tools for sensitive communication that you're not quite sure how it's going to go is question style and the use of what they call hypothetical questions. Have you ever wondered what your mum might feel if she really thinks she's dying and nobody else is talking about her with it? Have you ever wondered what that might feel like? For sensitive topics, closed questions, yes, no answers, won't explore, but open questions sometimes can be too threatening and big and not have a kind of a framework for people to work with. So hypothetical questions can be really helpful, but we'll talk about the 6-point toolkit in another session. But I think the absolute crux of what we're talking about, isn't it, is hope. And managing hope and distress, or hope and uncertainty. Hope is really individual. It's the patient's hope, not mine, not yours. It's the patient's hope, and what patients hope for may be different to what I thought I might hope for in that situation, but I'm not them, I'm me. So I need to ask, I need to explore what are the things that you hope for? And it may simply be a peaceful death. It may be a very simple, uncomplicated thing for the patient, but we need to ask it. It's really hard to explore if collusion is present. But that other bit of, yes, that's all very well, but I'm not to give false hope, but I've got somebody who's very distressed in front of me and I want to comfort them. How can I do that? And I think the important thing here is to think about, actually, what can I be certain about? I can be certain about when I'm going to see that person next. I can be certain that I've rung my surgical colleague. I don't know when he's coming, so I'm not going to say he's going to come tomorrow because I don't know that, but I know he's going to come. So instead of saying Mr. Smith's going to come and see you tomorrow, it would be, I've rung Mr. Smith, he will come when he can, but I have made that call. Try to avoid phrases such as don't worry or it'll be okay. Because people will worry, of course they will. And what does okay mean? Different things to different people. Acknowledging that uncertainty is difficult. And you can make a plan, even in that uncertainty. And it may be as down to earth as, I will see you again. I will let you know when I'm coming. So, rainy day thinking. There are ways to maintain hope, even in very uncertain situations. The other thing I think that people worry about is that once you open the door to conversations which are honest and open about death and dying, the house becomes completely gloomy all the time. But again, go back to that model of loss. And if you think about how we respond to loss, this wonderful, most recent dual process model by colleagues Strober and Schutt demonstrate that this is in grief, but it's the same principle. We veer between positive and negative ways of thinking. So you might have an open, honest conversation, but you don't need to keep on having it all the time. There may be times when actually what the patient and the family want to do is to go out, see relatives, pick flowers, lay the table, have a laugh and a joke. Life goes on around the situation that that patient finds themselves in. So you can sometimes reassure patients and families that actually that is what happened. It's just information giving, and life will go on around them. So the key message around collusion, don't forget it comes in different forms, intensity, it's not absolute. You may have more than one consultation where you broach it, and each time you do, it's a building block. But things may change between consultations. You are the bridge between the patient and the family. Use that approach of acknowledging, exploring, and validating. So I hope some of these issues have made you think. It's a fascinating topic and lots, I'm sure, that we can discuss. Thank you so much for listening.
Thank you. Thank you, Fiona. A fascinating talk. So our next speaker is Dr. Harun Hafiz. He's going to talk about collusion, a perspective from East.
Assalamu alaikum. Thank you very much, everybody, for inviting me to speak at this symposium, which has become the premier cancer meeting of this region. Today, I'm supposed to talk about collusion and communication, or truthful communication with patients, and that is why I have given the title of my talk to be "Truth May Hurt, but Deceit Hurts More." So the aims of my talk today are going to go through how we need to handle collusion and collusion requests, which are very common in our part of the world. I want to touch upon doctors' tendency to shield information from patients. I want to touch upon discussing patient information needs and explore the impact of communication on life-limiting illnesses and bad news with palliative patients on doctors. Before I start, the question I want to ask everyone is, economy with truth. Is that right or is it wrong? Are we right when we economize the truth? Or do we feel that it is important that we discuss the entire knowledge and prognosis with the patient as truthfully as possible? The British Journal of Cancer 2000-2001 did a study on UK cancer centers, and they involved nearly 2,331 patients. And it is interesting to note that 87% of these patients wanted a full disclosure from their doctor, whereas only 13% wanted that decision left to the doctor with regards to what information the doctor felt needed to be given. Interestingly, there is no difference between information preferences according to age, sex, tumor site, or nature of treatment, whether it was palliative or whether it was curative. So there is evidence out there that our patients want us to discuss the treatment options, the nature of their disease, and most importantly, their prognosis with them in detail. A common question that we are asked is, does this apply to patients from the East? You'll hear doctors saying that patients in the West are different in terms of information preferences and coping with bad information as compared to patients from our part of the world. Now, in 1996, Fielding and Hung in the journal Psycho-Oncology published a study essentially where they showed that the information needs of Asian patients were not much different to their Western counterparts. And then Roy and Kumar in 2005, in a study which was published in the British Journal of Cancer, showed that while different cultures may cope differently with the diagnosis of a life-threatening illness, there was no evidence to show that the patients from the West, or for that matter, as they put it, Caucasians adapted to the psychological trauma of a cancer diagnosis any better than patients from the East. So therefore, evidence out there is to the contrary. There is enough evidence out there that patients do want to know what is going on, and there is no evidence to say that patients in the East or our part of the world do not cope well with bad news, or at least they cope as bad or as good as patients from any other part of the world. So what are the issues? What happens when patients are not fully aware of their advanced nature of their illness? This is a very important question that we should keep in mind. And this question is addressed very well in the study published in Palliative Medicine in 2009 by Innes and Payne, where they showed when patients are not fully aware of their illness or the stage of their illness, there is unsatisfactory management, there are unnecessary hospital admissions, there is a higher proportion of hospital deaths, there is a lack of or late referral to palliative care services, which is extremely common in cancer services, at least in our part of the world, or our experience in Shaukat Khanum shows that patients are referred very late on. Even recently, data from just this year has shown that nearly 30 to 35% of patients were either referred within 24 hours of their death or not referred at all when they clearly needed palliative care input. This lack of information provision to the patient leads to poorer symptom control and suboptimal end-of-life planning. Now, end-of-life planning is a very important issue that whether we are in the East or whether we are in the West, we need to be able to discuss prognosis with our patients so they can plan their end of life. They can finish off any unresolved businesses, which are all essential components of having a good and a dignified death. Is it easy? Is it very easy to discuss bad news with patients? Is there an emotional impact of it? Yes, of course there is. So whenever we are discussing bad news with the patient, there is an emotional impact of that bad news on the patients and on the doctors and nurses who are providing that bad news. And that is why often we shield ourselves from doing that, because we have a fear of provoking distress, and then it is very difficult to handle those emotions in patients. Most healthcare practitioners fear extreme expression of emotion and tears, and they find it difficult to cope with that. And interestingly, doctors everywhere in the world assume that nursing staff are better than them at handling patient emotional distress because they seem to be closer to the patients as compared to the doctors. But that does not mean that doctors should shy away from their responsibility. They need to be able to sit down with patients and be able to handle the emotional trauma caused by delivering bad news or discussing bad prognosis. It is going to cause distress, and there was a recent study published in Cancer Nursing in 2001, which showed that senior oncology nurses, 46% of senior oncology nurses reported handling emotional distress as one of the most challenging aspects of talking to patients. So yes, it is challenging, and we need to learn to be able to do that. We need to be able to do that and cope with it. It is very important to contain one's own emotions. You see, most patients with a chronic illness, or if we are to talk of a cancer, since we are in a cancer conference and primarily a lot of our audience is professionals or healthcare professionals dealing with cancer patients, it is inevitable that these patients will be seeing us regularly for a very long time before their death or before they are diagnosed with metastatic disease and advanced disease, or before they reach that trajectory of their illness where things are going to go downhill. At that point, it is going to be distressing for the patient, and there is going to be a burden on us as physicians and nurses when we discuss that poor prognosis with them. But is it that bad to display emotion? It is not. As Finlay mentioned in her article, Your Child is Dead in the BMJ, it is very natural for us to feel distress and involved and feel some emotion when we are discussing this bad news with patients. Sometimes some doctors try and attain a posture of cool detachment. It is thought that this is expected from physicians, but it actually can give a signal of evasiveness or a lack of empathy to our patients. They expect us to be involved. They expect us to show some emotion. Although, do not start weeping hysterically when that happens, because it is important that you maintain your calm, you are dignified, you can show your emotions. It is important and it is natural, but it is also very important to maintain a certain calm and keep control of the situation, because at the end of the day, this consultation is being done to discuss prognosis, to explain the nature of the illness, and making sure that patient is aware of what's going on. So what do we do when we are faced with difficult communication scenarios? We tend to minimize. We tend to economize with the truth, as I said earlier in my rounds. I'm just going to go through a consultation that I came across in one of the communication skills books that I was reading. So the doctor sees this patient and he says, remember at the start of chemotherapy, we told you that your bloods and chest X-ray will be checked with each cycle, and your latest tests show that things are progressing. Therefore, I do not think you should have any more chemotherapy. Now, what the doctor is trying to say here is that actually this patient's disease, despite all treatment, has progressed. He's in an advanced stage of his illness, and therefore the doctor is making a cautious decision to stop his chemotherapy. So the patient asks, what will happen now? And the doctor says, well, we want you to come and see us if there is an issue with your breathing, and we will treat the symptoms. And the patient says, thank you very much, doctor, and walks out. So what the patient understood over here is, it's all good news, really. The doctor thinks that things are progressing, so I don't need any more chemo, and therefore I only need to come back if my breathing starts playing up or I start getting breathless, Now, recap the discussion. The doctor was trying to say exactly the opposite things. By using the word progressing, he meant that the illness is progressing. The illness has gone into an advanced stage. The illness has gone into a stage where we cannot offer any more chemotherapy. And the only thing we can offer is to try and control the symptoms. And the patient, because the communication was done in a manner that things were not explained, has taken home a message which is completely the opposite. He thinks that things have progressed well, and therefore he does not need any more chemotherapy, and therefore he does not need to bother with coming again and again to the hospital, and should only come up if his breathing plays up again. By going through this conversation, what I've tried to show over here is the impact of economizing or minimizing or avoiding a clear, frank discussion with patients. So there's another study that tape recorded consultations from 118 patients with advanced cancer. And they reviewed those consultations and came to the conclusion that about 84.7% were told the aim of the chemotherapy that was being administered to them. But only 25% were told that their cancer is incurable. Only 42% were not told their likely prognosis. So 58% were told the prognosis, 42% were not told their prognosis. 69% were not offered choices in management. Now, it is very important for patient compliance that we offer them a choice in management of their disease. And this is most important. Only 10% of patients at the end of the consultation were asked for whether they understood what had been discussed. And if we now go back to the scenario that I just showed you, had the doctor checked patient's understanding, he would have arrived at the conclusion that this patient had not understood anything. The doctor was trying to say that your disease has progressed and therefore we cannot give any more chemotherapy. But what the patient understood was that things have progressed well and I do not need any chemotherapy. There's a slight difference here. So discussing prognosis is very important. 98% of patients with advanced incurable metastatic disease want their doctor to be realistic. They want to know and discuss expected survival when metastatic disease is first diagnosed. So it is very important that doctors, when doing this, must give hope, but at the same time, they must be able to reassure their patients that yes, the disease is advanced, but we will try and control your symptoms. We'll try and make sure you're comfortable, and we'll try and give you all treatment options so that you have some control over what is going on. It is very important to balance hope and truth-telling. When I say truth-telling, I do not mean that we need to shove information down a patient's throat in all technical jargon and in detail. But what I'm trying to say here is that there should be a candid, frank discussion with patients about their disease, about their prognosis, about the stage of their illness, and about what treatment plan is going to be offered. And also, most importantly, what are the expected outcomes of their treatment? That is very important. So what happens when patients are told the truth about prognosis? A very common argument that we hear is that patients should not be told. They will lose hope. They will be overwhelmed with depression. There will be an information overload. They will not enjoy whatever time is left. These are all common things that we hear from patients' families when they make requests for collusions. And these are all common scenarios that we hear from doctors who feel that they are too busy to sit down and spend time in detailed conversations, and therefore they minimize the information that they want to give to their patients. There is no hard evidence in support of all this. It does not work this way. It is not right to shield information or assume that patients will lose hope because you've told them the truth. In fact, in the European Journal of Palliative Care in 2005, in an article, they showed that misguided evasion or frank dishonesty actually adds to the patient distress and prolongs the adjustment process. A patient needs some time to adjust to their advanced disease. They are already suffering from an advanced disease. The last thing they need is to have unclear communication or unclear signals from their medical team, not be sure about what's going on. Therefore, what happens when we do not, when we do not tell patients the truth? They seek unnecessary treatments. They continue to come to hospital again and again. They have poor symptom control. They often end up in a coma or die before they've had the time to properly say goodbye or properly resolve all their unfinished businesses and affairs. So please, 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 if there is one thing I want to discuss here, I want to discuss that please make sure patients are made aware of their prognosis. Families will come up and will request for collusion. That's always going to happen. And they're doing that because they want to protect their loved one. It is very important that you handle those collusion requests by going through the reason why you want the patient to be aware, the evidence behind why patients need to be aware, as we've just discussed, and the importance of frank discussions with patients. Concealment of truth is rarely achievable. What will happen is that the patient will lose trust of the family and will lose trust in the medical team. And then they will feel more alone and more vulnerable, which is exactly what we are trying to avoid at this stage of their illness. So it is very important when you are dealing with collusion requests, you go through all of this evidence which supports that the patient needs to know, and unless obviously the patient in his own state of mind, being compos mentis, has actually requested for no information, then that's fine. But until then, patient has a full right to know. There is no evidence that patients who have not been told about their terminal situation die happily in blissful ignorance. It does not happen that way. Collusion with relatives of dying patients in an attempt to sustain the myth of immortality is an abrogation of our responsibility to assist the patient through the stages that might be needed more for people to achieve a calm acceptance, a serene and dignified death. Very, very important. The typical thing, don't tell my mother. Ask yourself, go back to those age-old principles of ethics. Does the mother have a right to know? Yes, she does. Would it help her to know the diagnosis? Of course it would help her. She would be able to plan things. She would be able to manage things. She would be able to cope with her symptoms. Would it harm them to know the diagnosis? There is no evidence, as we have seen so far. Therefore, when these requests come, you need to handle them. You need to try and get to the bottom of them. You need to understand the family is doing in trying to protect their loved one, but that is not the best way of doing things. In the end, I would like to summarize by saying what we have discussed. Often as medical practitioners, we are guilty of underestimating our information needs of our patients. We should not assume that patients from the East or this part of the world are any different from patients around the world, and therefore they do not need to know about their illness. It is understandable that we are obviously more comfortable discussing positive news rather than end-of-life issues, but that does not mean that we shy away or abrogate our responsibility of doing that. We need to ensure doctors at all levels of training are aware of communication skills training and access them to make sure that they are doing appropriate communication in a proper manner with their patients. If we do that in an empathic manner, in a timely manner, patients will cope with bad news. We obviously have to balance hope with truth telling. We have to give our patients hope, but the right hope. We should handle collusion requests by addressing the family concerns as I've just discussed and making sure they understand why it is important for the patients to know the truth. We can never lie to our patients. In the end, I'll quote Hippocrates that I think the best physician is the one who has the providence to tell to the patients, according to his knowledge, the present situation, what has happened before, and what is going to happen in the future.
Thank you, Dr. Harun. An exciting talk. And just for the audience, I would like to add that if you have any questions, please do write them in the little chat box, and the panelists will take these questions towards the end of the session. So our next speaker is Dr. Aoife Gleeson, who is a consultant in palliative medicine at Royal Gwent Hospital. She is honorary senior lecturer at Cardiff University and also clinical director at Aaron Bevan University Health Board. Her key areas of interest include palliative care for non-malignant respiratory diseases and infection control issues in palliative care. She's going to talk about end-of-life care during COVID-19 pandemic.
Good morning. My name is Dr. Aoife Gleeson, and I'm the Clinical Director for Palliative Medicine in an Aaron Bevan University Health Board in South East Wales in the UK. It gives me great pleasure to speak to you today on end-of-life care during the COVID-19 pandemic. I'm going to provide some context and give you an outline of the setting where I work and the infrastructure of the service. I'm then going to go on to speak about the response that I led in terms of palliative and end-of-life care COVID-19 response during the pandemic. I will give you an outline of the key priorities that we set ourselves and the key outcomes, and then comment on the impact on practice and patient care that resulted. So an Aaron Bevan University Health Board is in South East Wales, which is in the UK. And until November 2020, the 5 boroughs in our health board, which you can see on this map, they're split into their subsections as well. Within the 5 boroughs, we had 3 district general hospitals and a 15-bed hospice. Due to the impact of the pandemic, and in particular, the need to have increased ventilatory support on one site, we brought forward the opening of our new critical care centre by 6 months It was due to open in April 2021, but instead it opened in November 20. This gave us surge capacity to be able to ventilate up to 118 patients on one hospital site. This has obviously had an impact on the 3 existing enhanced local general hospitals, and we still have our 15-bed hospice. During the pandemic, my main ongoing role was to provide clinical leadership as the clinical director for the Bevan University Health Board Palliative Care team. Initially, that was to provide that support for 3 hospitals, for our hospice, and the 700,000 community that we support, as we also support a third of another health board, so South Powys. And obviously, since November 2020, that has expanded to supporting 4 hospitals, including a critical care centre. I'm also the Wales representative on the Association for Palliative Medicine for Great Britain and Ireland, and so was involved in the APM's COVID-19 response and guidelines. And additional role that was set for me, or that I was asked to take on during the pandemic, was to be the palliative and end-of-life care COVID response lead for the health board. In setting up that group, and I was informed of it and had the group set up within 24 hours. The group was a cross-sector, cross-organisational group, taking into account and making sure there was membership from both statutory and third sector, so voluntary organisations that were involved or stakeholders in providing support for patients with palliative care and end-of-life care needs. We had fortnightly meetings, and that forum was there to ensure that everybody was kept up to speed, that there was regular and complete communication between sectors. And the main issues that we kept on our agenda for that were personal protective equipment, staffing issues, medication and syringe driver issues, considering that we do support a lot of people with complex symptoms and patients in the last days of life through giving medications through syringe drivers. And also a last item on the agenda of communication planning for the pandemic and between sectors and between settings. We also, one of my roles was to twice a week feedback at divisional operational group meetings, and I on behalf of the group linked specifically with the tactical and the strategic groups for specific issues. Essentially, our health board set up a bronze, silver and gold response, where bronze was operational, silver was tactical, and gold was strategic. So in terms of the key priorities that we set ourselves, I mentioned that we that one of the areas was communication. So we were focused on communication between patients and palliative care healthcare professionals, and that was key, making sure that patients, that we were optimizing and prioritizing ease and development of better communication systems for patients with palliative care healthcare professionals. Also concerned with the communication between palliative care and other healthcare professionals between different settings, so third sector and the NHS, and between, as I say, settings between community, hospital and hospice settings. And in the community setting, also specifically thinking about the care home setting. We also were saw as a priority the dissemination of updates to guidelines, policies and protocols, and to ensure an appropriate level of care for all patients through optimizing communication. So another area for key priorities was medication issues. So we wanted to ensure access to medication and medication delivery devices for all patients, and to ensure equity of that access. We wanted to optimize patient access to medications. We were aware that there might be shortages, and we might need to look at second line medications and look at ways to optimize patients being able to actually get those medications when they were isolating at home with COVID-19. And when there wasn't the possibility to be coming to GP surgeries to collect prescriptions. We wanted to look at developing protocols for second-line medication options and to ensure wider dissemination of updated guidelines and protocols, especially with regard to second and third line medications, and what to do if there was a shortage of medication delivery devices, such as syringe drivers. In relation to staffing, our key priorities were to ensure optimal support to palliative care staff in all settings, to ensure adequate staffing to support palliative care patients in all settings, to develop a community hub model so that if there was extreme shortages in terms of staffing and resourcing throughout the health board, that we would be able to develop an escalation system so that patients would get the emergency and the urgent access that they needed to community support. And also to develop appropriate staffing escalation processes so that if we were short in staff, that we'd be able to identify additional staff or workarounds so that we could still provide an optimized service. Another key priority was looking at personal protective equipment and infection prevention and control. We wanted to ensure access to PPE for all teams, and in particular for our third sector, so voluntary sector teams. Our voluntary sector provides community support, so the nursing community support, which is then supported by the consultant team, which I'm responsible for. And we also provide all of the medical support to our inpatient hospice unit. But again, that hospice unit is run by a third sector organisation. So we wanted to ensure optimising access to PPE and also infection prevention and control support. We wanted to develop escalation processes for infection prevention and control and PPE equipment issues. And through our fortnightly meetings and regular bulletins and feedback from those bulletins, we were able to provide a very secure and reliable escalation mechanism to ensure no problems with PPE or infection prevention and control. And we also wanted to ensure that we had protocols and guidelines that were up to date and disseminated in real time to all interested parties and all clinicians involved in supporting our patient group. So just to move on to our key outcomes. So going back to communication, purely through the fortnightly meetings that we set up that provided a forum for all interested parties and stakeholders to be able to get an update and to actually feedback issues. So community, hospice and hospital were all represented, so we were able to actually escalate any issues up through the health board, through the bronze, the silver and the gold groups. It also meant our third sector partners were kept up to speed on all the developments within the health board in terms of changes to everything to do with infection prevention and control and PPE planning. We developed a single point of access within our hospital palliative care team. So we developed a single point of access phone number, which would allow us to support patients, so referral of patients, referral for family members, so family members who couldn't see their loved ones, who had worries and concerns, or who we needed feedback information about the patients. There was a second line for them, and then there was a third line through that single point of access for staff members who were looking for support or advice. We had to think on our feet, as everybody did during the pandemic. Things changed very quickly. So this enabled us to be able to provide in real time basically guidance to staff to pick up on issues so that we could actually develop our guidance and our hub. So the intranet hub, and there's a small, I suppose, screenshot of it here on the right-hand side of this slide. But we developed within the COVID-19 Internet Hub that we had in our health board, we developed a palliative and end-of-life care section where we kept up-to-date secondary care guidelines, link to primary care guidelines, link to our guidance on care decisions for last days of life, and that's an all Wales guideline. We had helpful information there on the absolute essentials of symptom control for people who were dying from COVID-19, who weren't for ventilation, who weren't for escalation to the ITU or to high flow oxygen or non-invasive ventilation. Yeah, all of that was available through this internet hub. I led on an all Wales basis for the development of the Attend Anywhere video conferencing and consultation platform in this from a palliative care point of view. So we developed the business and user model for palliative care video conferencing and consultation. We also developed a new bereavement support framework that was launched within and during the pandemic because of the huge increase in need for bereavement services. We had to think on our feet, and we developed a lot of information, leafleting, and a brand new hub for all of that. And that, unfortunately, is out of the scope of this talk, or I could just talk for the rest of this talk on the bereavement support framework that we developed. Also, in relation to communication, I am also the strategic lead in the health board for advanced care planning. And so as within that role, we also developed electronic advanced care plan records and an all Wales treatment escalation plan policy, and a very clear guidance on where these should be used. So the treatment escalation plan policy that we developed was developed with a view to using in secondary care, so in the hospital setting, so that we would be able to ensure that the people who would benefit most from with COVID-19 cases, that who would benefit most from either invasive or non-invasive ventilation would actually access it. I also was the lead in developing the secondary care COVID-19 palliative and end-of-life care symptom control guidance. We developed symptom control stickers for use in emergency areas such as the accident and emergency department and other red COVID areas like in the intensive care unit, and also our high flow, high intensity respiratory COVID area. And all the way through the pandemic, we delivered hot and virtual teaching. So we would go on to wards, maybe 30-bed wards, where there were 5-6 patients dying in each 6-bed bay, and actually gather the staff together and basically provide hot teaching to nurses, doctors, healthcare support workers, all in the one forum. And equally, we provided a lot of virtual, as the technology caught up, virtual teaching over Zoom and over Teams to all of our 4 hospital sites. In relation to medications, we ordered an additional 50 syringe drivers. There was an order for all Wales. We were the health board that was hit hardest first. So we were able to get a delivery of quite a number of syringe drivers, which was very helpful. We developed symptom control protocols, and in particular, protocols for second-line medications, and also within those, protocols for what to do if a syringe driver wasn't available and somebody was requiring basically regular and continuous symptom control. We also at an all Wales level, we're involved in developing the reuse of care home medications. And in conjunction with pharmacy, we were able to launch the reuse of care home medications policy. Just to say, as the legislation may be different here, but if medications are dispensed to a patient before COVID, if those medications weren't used, they would have to be returned to the pharmacy and destroyed. But this allowed us to, where there was shortages in medication, to actually reuse medications that had been originally dispensed to another patient. And also with our pharmacy, through our group, we were able to disseminate a protocol for the access to the All Wales Medication Hub, because during the COVID-19 pandemic, the Army were drafted in to be able to deliver medications in short supply from 5 different hubs around Wales. Key outcomes from a staffing point of view was that I led the team at 3 hospital sites, which became 4 hospital sites, that my leadership helped to increase the confidence of our team to go out and support patients who were COVID-19 positive. In order to increase patient support, we had to alter our referral system. So usually we use an e-referral system, but as I mentioned already, we set up a 1 point of phone contact and phone access. So we altered our referral system to keep up with the demand. We also identified additional staffing to help us in specialist palliative care. There's very few people who were trained, but we were able to secure an extra CNS and a doctor who were both trained well in palliative care. And we put an escalation process in place to use hub models so that we could use our staff as best and as wisely as possible to meet as much demand as possible. A community hub was established, which was enabled us to have a model for cross-specialty working, which thankfully we didn't need to use. From a PPE and an infection prevention and control point of view, a link was established between the third sector and the NHS for PPE access, and that worked very well throughout the pandemic. From an infection prevention and control point of view, we made sure that we had a reliable single point of contact for our third sector colleagues. And I was also a lead in development of our health board, so Gwent-wide end-of-life care visiting guidelines for the hospitals, and those were emulated for the hospice setting. So in summary, in facing into the pandemic, when I was tasked or asked to lead the health board's COVID-19 palliative and end-of-life care response, we hit the ground running. So it was a dynamic response. We changed up as there was a need for change. So we responded in real time to the clinical scenarios we were faced with. This has helped to strengthen professional relationships, certainly working very closely with the teams and meeting fortnightly during the pandemic was really helpful. The absence of red tape, because traditionally, obviously, bureaucracy and red tape get in the way, but we were able to achieve a lot in a very short space of time. So from the point of view of our achievements, we developed, and I led on the development of the All Wales Palliative Care Virtual Consultation Platform. Our health board is basically we have led on the All Wales Treatment Escalation Plan policy, which is in place now for all of the 8 health boards, with e-learning and guidelines and patient information leaflets, and that policy has been, as I say, accepted and taken forward as the All Wales Treatment Escalation Plan policy. I also led on the development of the electronic advanced care planning record and policy development, which is being used in our health board. I would like to obviously take this opportunity to thank the conference organisers for asking me to speak, and I'd be more than delighted to take any questions that you might have. Thank you.
Thank you, Aoife. A great talk again. Many thanks. So our next speaker is Dr. Chris Farnham. He is a senior consultant in palliative medicine at East Kent Hospitals University Foundation Trust with medical director experience in both public and third sector organizations. Joining him is Lucinda Warlock, who is voice and communication coach with over 20 years of experience. She has been a former in-house voice and communication lead at Royal Central School of Speech and Drama. Welcome, Chris and Lucinda.
Hello, everybody, and welcome to this final session of the Palliative Care Morning. So this session is entitled When It All Goes Wrong, How to Stay Present and Connected. My name is Dr. Chris Farnham, and I'm a palliative medicine consultant at the East Kent Hospitals University Foundation Trust in England. And I'm going to be presenting this session with Lucinda Warlock, who will introduce herself in just a moment. Lucinda and I first met many years ago when we did a project together, bringing some of the world of actors and medicine together to see if we could help doctors communicate better, particularly with each other, but also with their patients. And the purpose of today's session really is to try and build on some of that work and see whether or not there are some elements of the work that Lucinda does and some of the work that I do, and see if we can bring those together to help with our communication, particularly when, as we say here, it all goes wrong. And we'll be exploring that in just a moment. But I'll let Lucinda just introduce herself. Lucinda.
Hi, thank you, Chris. Thanks for your kind introduction. As Chris has noted, my name is Lucinda Warlock, and I'm a voice and communication coach. And what that means is I spend my days training actors and training who I would term business professionals, which essentially is anyone who's not an actor. So I've worked with Chris on projects around building empathy skills for medical professionals, particularly around the work of end-of-life care. But I also help boxing commentators know how not to lose their voices, or help senior chair people prepare for a hustings, or a politician to find a new way to connect to everybody in a speech. Or I might prepare somebody for a speech at a wedding or a eulogy at a funeral. And in all of those encounters, my goals really are to draw from the world of actor training to help people to connect to the emotional truth of what they're saying and really connect with their audience. Today, we are going to be working with you within the clinical setting. And really what I love Chris to do is just to set the context, particularly within the last 18, 20 months of working in your roles, but with the added stress and uncertainty of the global pandemic.
Thanks, Lucinda. Okay, so just as Lucinda has alluded to, we want to try and make this as clinically relevant as possible. Now, given that this is a conference based primarily with people from a cancer background, and obviously those of you on this call will have a palliative care interest, we know that over the last 18 months, it's been particularly difficult trying to communicate patients, but also probably with their families and relatives more so. When they haven't been present, they haven't been physically present, we've had to do some quite difficult communication over phones, over Zoom, over the telephone, but sometimes in face-to-face. We haven't had much time to prepare people and to get them up to speed with what we're thinking and feeling. So that's been very difficult. And we've all experienced some very challenging moments, I suspect. But we do that anyway, I suspect, again, in our normal practice. So whether or not you're working with cancer patients, with dementia patients, with end-stage heart failure, renal failure, working in the community or in hospitals, we've all had situations where we've had to give bad news, where we've had to deal with angry relatives, or patients who become distressed because the thing we're telling them doesn't match with an expectation that they had. So what we want to do today is to think a little bit about how we can prepare ourselves. And this next slide that you see, just for me, is a very visual representation of sometimes what we feel, but also sometimes what colleagues or patients or their relatives feel. It's just too much. It's absolutely too much, and it feels chaotic. There's an awful lot of noise. There's an awful lot of emotion, but we have a job to do as a doctor or a nurse, and we have a job of telling our audience. So this is why we're using the sort of actor analogy, really, is we need to tell our audience something. We've got a story to tell, and they need to hear it, and they need to hear it clearly, and they need to understand it. And this is where we're going to be using Lucinda with all of her background and all of her skills to tell us what she does with some of her clients. So drawing, as you've heard, from the acting world and applying that to her clients, and how we might take some of that and apply it to some of our clinical scenarios. So there are clearly, we can't do all of this, and all the stuff that Lucinda does, I don't want to paraphrase at all, but I mean, Lucinda, you will take days, weeks, hours with clients and with people you're working with, and some really complex stuff. And we've only got a few minutes here, really. So we're just going to take little snippets. Lucinda, I don't know if you want to go through the aims at all.
Of course, yeah, thanks, Chris. As Chris has done beautifully, we wanted to start by really just having a quick conversation around how we are, within the clinical world, how these complex situations or high-risk interactions might take place. So just to contextualize them for you in order to understand the need and the relevance today, and how this session fits into the symposium, but also into the broader aspects of your roles and everyday lives. And then really introduce you to three key concepts around the area of what I might term self-management. So why awareness, acceptance, and intention are really key tools to understand, but also to be able to apply in your clinical practice. And from there to explore presence, this idea of connection. How can we practice presence and be fully in the moment, and how might that help us to be in more of an optimum state to deal with some of the challenges and uncertainty that we find ourselves in.
So if we think about the clinical setting, what we're going to do first of all is I'm going to give you an imagined but very real in many ways clinical scenario, and we're going to keep just referring back to that through some of these little sessions and bits of management that we're going to do now. So you're a doctor or a nurse, and you've been treating an elderly gentleman in his 70s for lung cancer. And initially he'd been responding quite well to chemotherapy, he's had some radiotherapy, but now this disease is progressing and he's frail and he's no longer suitable for further chemotherapy or any other treatment that you might have available to him. And really, he's going to be nearing the end of his life, and he's going to start to die soon. And you're going to be going in to talk to both him and his wife and his two children who are waiting to see you. So you're going to be telling them a little bit about what's happening. And so that's the clinical scenario, and we want you to keep that scenario in your mind as we go through this session. Thank you, Lucinda.
Thank you, Chris. As Chris has outlined, we have a scenario on which to start to apply these techniques and these concepts to. And I want to reiterate that in any high-risk scenario, the impact that it has on us, it can affect then our communication. And in the world of actor training and communication training, we would separate communication in 3 pillars. So your body, your breath, and your voice. Now, I'm sure we're already mindful of this, right? We know that the majority of our really conscious communication happens in the words that we choose, and potentially as well, there's a certain amount of control in the way that we use our body language to communicate. Ideally, when we're fully in the moment, that happens congruently, right? That we're able to communicate our message clearly, and our body and our voice tell the same story. And when we're working or interacting with people and their body and their voice are telling us different stories, something doesn't add up, yeah, or our attention is pulled. The link between the body and the voice, and certainly a big part of an actor's 3 years training, is breath, yeah, the energy, the fuel for life, but also the energy that communicates your message clearly. So I want really us to take some time to just tune into one of those pillars briefly now, and that is the breath. Because the impact of fear, of blame, of uncertainty is how it activates our sympathetic nervous system. So we know it has psychological impact, but also it has a physiological impact too. When we are able to breathe calmly, we are more connected to ourselves and therefore more connected to others around us. We can be fully in the moment. And that's why so much of the world of meditation and mindfulness, stress and anxiety management is around really fully immersing ourselves in breathing. So I'm going to invite you first to breathe with me in a very simple exercise that I hope you're able to do and join with us now. I'm sitting down. We're going to stand up in a moment, but let's sit for now. I'm going to find the ground beneath my feet, which I'm going to take away any mystery of what that means. I'm just going to find the ground under my feet. I'm going to walk my bottom to the edge of my chair. So I'm not just sort of sitting back and comfortably observing. I'm going to be a much more present, much more active. So my feet are hip distance apart. I'm sitting on my sits bones. I'm going to draw tall through my spine. And Chris, please join us with this. I'm going to place one hand on my heart and one hand on my core, yeah, or my belly. And all I'm going to invite you to do is just breathe in with me. If you're able to breathe in in your nose and out through your mouth, let's do that. If you're not, no worries at all. Do what is working for you today. So all we're going to do is breathe in for a count of 3. So 1, 2, 3. And breathe out for a count of more than 3. So 1, 2, 3, and more. Whatever that means to you. Releasing lower abdominals, and then when you're ready, let's come in again. And out. 1, 2, 3, and more. And let's keep going. A couple of cycles. And out. And in. And out. And in. And out. And in. Out. And just let it go for a moment. Soften your gaze. Bring your awareness into both hands and just tune in to any light movements that you're noticing. As that new energy, as inspiration travels through the body, you might notice a sense of lengthening through the spine, of softening in the belly. There might be more feeling of groundedness and anchoring through the bottom and the feet. A feeling of calmness, of clarity, of focus. Now that took less than 2 minutes, but again, a regular reminder to ourselves of the need to tune into ourselves, yeah, particularly when dealing with situations that are outside of our control. How can we start first with ourselves and just tune in and notice what's happening? Chris, how did you get on?
But just about to nod off, I think, just so relaxed with that.
Okay, good. So you're feeling more relaxed, I'm feeling more focused. So again, great to know that actually an easy exercise like that, has a different impact on us depending on what we need in the moment. It needn't be more complicated than that. So that's the breathing in for 3, breathing out for more than 3. And ultimately it's about connection. Yeah. So it's the same way that an actor would warm up before performance, or an athlete would take their time to stretch and then visualize before competing. What are we doing in those high risk situations to really ground and anchor ourselves before then coming into that situation? So managing your energy state really starts with awareness in the here and now, in the present, and in your breath. Can we take some time to move into acceptance, Chris? Is that all right with you?
Of course, thank you. Do you want me to talk a little bit about that, or how would you like to?
Absolutely, if you want to, and I can always jump in.
So just building on what Lucinda's done with us, I think in medicine, very rarely when we're having conversations and when we're talking about advanced comms training, do we ever think about preparing ourselves for conversations in this way. So just as Lucinda alluded to, an athlete always prepares before they start a race. An actor prepares before they go on stage. But we don't prepare for these difficult conversations, and the impact of getting this wrong, or the legacy of getting this wrong, can be huge. So it's connecting with ourselves, as Lucinda talks about, and we talk about acceptance next as a concept. So using our example of the elderly gentleman with his lung cancer, and we're describing what Lucinda described, or how she told me about this, and I understood it, was like a layer of onion skins or an egg yolk, in as much that there's a lot of stuff outside, a layer outside, that we can do nothing about. So we cannot change the fact that his cancer has not responded to the chemotherapy or to the radiotherapy. If we come closer in, we can't change the fact that he potentially will be very upset, his wife will be very disappointed, or his children may be very angry. It's understandable. He may also be very quiet and not very angry. So it could go either way. What we can do is to accept that there is one thing we can do something about, and that's about our thoughts, our feelings, and have some control over those. So it's accepting the things that we can have some control over before we go into these high-risk situations, and accepting there are things that we just can't do anything about, and nor should we try to waste valuable energy in trying to change things that we can't change. So it's thinking about those very, very core things that are integral to us and that we have some influence over. I think is that correct, Lucinda?
Yeah, yes, absolutely, Chris. I think, again, so much of our what we know about the world of meditation, and certainly drawing from the world of Buddhism, this idea of being aware but also accepting that which we can't change. So I think it can be, and again, I speak outside of the medical profession, but I imagine enormously a huge load to carry when you're in those situations regularly, and there's nothing you can do, right? So what can we do? I think, and this is where that circle of control, or I prefer the word management, is how can we manage ourselves? So how can I build awareness of my energy level today, of what I'm noticing and feeling in myself, and without masking it or covering it up, take some time to get into optimum state, to get into the zone, which is dealing with myself first. How am I? How's the other person? What are they going to need from me? And how can I manage myself, my thoughts, my words, my actions, to influence them and connect with them towards the same goal? So all you can control or manage is yourself. And that starts with awareness. And it's the acceptance that everything outside of that drawing from the world of COVID, it might be that we draw a circle of, sometimes when I'm working with clients and participants, we draw a circle of concern, and I get them to write down all the things that they're worrying about, all the things that stress them out. And it might be climate change, yeah, living in a pandemic, yeah, losing my job, all of these things that they're worrying about. And then the inner circle of that is this circle of influence. What can I influence? And actually people's actions, yes, people's thoughts, you can't control them. You might have some ability to be able to influence them, but this inner core, this what can I actually control, is you. Your thoughts, your words, your actions, your values, your story. And I don't think we often spend enough time sitting with that. So again, it starts from the place of awareness and recognizing the need to set your intention, which we're going to explore, because when you are in a situation that is fast changing and stressful, and you're having an emotional response to that, again, really healthy that your sympathetic nervous system is firing up. You want to listen to that, pay attention to it, accept that, just as you accept other people's actions, and then know that there are things like breathing exercises, we'll come into a short warm-up in a minute, to manage that. So you're able to be fully in the moment, but also able to make sure that your thoughts, your words, your action are all aligned with your goal. So what I want to do is come into building, because as you see, these are all interrelated. It's quite hard to isolate them. Come into this idea of intention, because I think in English language, it's really different how we use the word intention than how we use it in the world of actor training. When I'm talking about intention with somebody, it might be that they come in with a speech and they say, oh, I've got to do this speech or this presentation. And I'll say, okay, well, what's your goal? You know, what do you want to achieve? And often people say things like, well, I just want everyone to think I'm really good. Or I just want to be impressive. And I think, okay, well, how are you going to, like, if this was an actor, how do you act impressive? What is this? It's the physical manifestation of being impressive or being good. So that's when we have to come back to really stripping away the layers of what's my goal? Yeah, what am I here to achieve? And how am I going to do that? So we normally start with an audience perspective. And I'm going to use the word audience here to mean anyone else you're speaking to, you know, the other person. So in Chris's scenario, it could be the patient himself or any other member of the family. So the other person. So who's your audience? What are their hopes from this interaction? Yeah, what do they really hope you're going to say? What are their fears? Yeah, what do they not want you to say? What are they worried you're going to say? And what do they need from you right now? So always consider that. I think that has to be at the beginning. Then there's the who. Then there's the what. So they were the who. Then there's the what, which is what's my goal? And it might be that your goal is to give them an update. Yeah. It's to give them an update, to inform them. How you do that is your intention. Yeah. So the what is your objective? How you give them the update is potentially going to break through the barrier, which is all their hopes, fears, and needs. So that's the obstacle that we're sometimes fighting through. So, Chris, can I ask, if you had to go into a scenario like that, would an objective like informal update be fairly realistic? It might just be that there's a bit of information you have to disclose. Mm-hmm. And if they had hopes and fears and needs, how might you do that? What might be an example of how you would align your intention? What would your intention be?
So in the scenario that we've given, I suppose my intention, which is, I suppose, my ultimate goal, is for them to understand that there are no more treatment options, and that this will mean that the patient will be dying. That's my intention. The difficult bit is how you get everybody to hear that, because, as you say, the fears are that, so their hope is that I'm going to tell them everything's going to be okay and everything's worked. The fears are that I'm going to tell them things haven't worked. And through that fear, I suppose there could be a lot of emotional noise that stops my intention landing. So your lovely little diagram of the arrow landing on the center of the target, which is my intention, for them to hear that the treatment hasn't worked and that they're dying.
Okay. So can we break this down further? And can I ask you, we're going to jump into a warm-up in a minute, but what I want to do first is really pinpoint a phrase that we can use, because again, this is complex work. We're looking at, you know, a very small crumb, really, of a big pie of possibilities. And a phrase that you might use when you are maybe going into that situation, and either the first thing that you might say to them, or a phrase that whether you would introduce yourself. Can you think of something that you might say that we can apply this work to, just so we can look at a very small moment in this scenario?
So just starting, I mean, it seems very silly and very simple, but just saying my name and what my role is. So I'd say, hello, my name is Dr. Chris Farnham. So sometimes people think now we're all wearing scrubs, they may think I'm a nurse, or so it's for them to understand my name and my role. And then I'd say I'm a palliative care doctor. And sometimes, as we all know, people don't want to hear that they're being seen by palliative care, because they assume that means that they're straight away that they're imminently dying. So that's not necessarily what people want to hear, and they may disengage. So I suppose it would be, hello, my name's Dr. Chris Farnham, and I'm a palliative care doctor. Would often be how I'd introduce myself, but with all those sort of fears and concerns that I have about saying those things to people.
Okay, thank you, Chris. So your goal then would be to introduce yourself to them, and then your intention, again, depending on who is in the room and the, you know, the complex set of needs, depending on who those humans are in that particular moment. One intention could be that you come in and you reassure them, for example, right? So from the minute that you say your introduction to them, the minute you introduce yourself, that yes, you're introducing yourself, but you are saying it in a way that is reassuring as soon as they hear your name. Could we practice? And again, I'm sorry to throw this on you, because I know I did. We haven't jumped up and done anything, and I'm throwing in the deep end. But what I really want to do is just really interrogate what we mean by intention, because I know it's something that we throw around a lot in acting without necessarily always translating it to everyone else. And I wonder if you could, let's stand up and just introduce yourself again, but could you do it with the mindset that you are reassuring me, and don't overthink it. Trust that your body, your breath, your voice, everything about you as a feeling human and not a droid will know how to reassure me. Can you just introduce yourself again, with the goal being to reassure me?
Hello, I'm Chris Farnham, and I'm one of the palliative care doctors here. Lovely.
Now, just before we unpack what that was, can we see something different, just so we can see that this is intention in action? Now, this might feel absolutely inappropriate for the setting, but I think it would be really interesting to see the contrast. Could you now just assert? I want you to just to really assert yourself. And so you are going to make me feel commanded, I guess for want of a better phrase. So I want you to come in, be very assertive, and get my attention, demand my attention with that same phrase.
Hello, my name's Chris Farnham. I'm one of the palliative care doctors here. What do you want?
Oh, okay, great. So what we're seeing beautifully, Chris, is a huge contrast between both of those two. And without wanting to start, pinpointing like, well, what would be most appropriate, what wouldn't. What we're seeing is flexibility in your delivery, in your vocal tone, in the pace, in your body language, in your expression, in your gestures. Can you feel that we're doing this COVID friendly way at a distance from each other? As we've got about 7.5 minutes left, despite what it says on the timer on the screen. So I'm going to lead us on a quick 5-minute warm-up just to connect us to each of these three, and then we're going to come through a quick checklist before we finish this very, very brief dip our toe in a complex pool, this 40-minute session today. So taking time for a regular warm-up can feel really idealistic. Actors train for 3 years to really ingrain this work in muscle memory, so it's there when we need it. But again, when I'm working with business professionals, I realize that we don't have that same luxury of time. So I would offer this out as an exercise or a series of exercises to use on a day that maybe doesn't feel like a good day or an optimum day. So when you're feeling tired or stressed, or when you know that there are some complex conversations or interactions ahead of you, rather than coming in with dread or fear, giving yourself a couple of minutes in a private space, like an office or a meeting room, or even a large disabled toilet room, if there's space, to just tune in to those 3 pillars of communication. So your body, your breath, your voice. I want you to start with your feet connected to the floor. So Chris, I am standing with my feet hip distance apart. I'm going to tuck my pelvis. So really think about my sitting bones drawing together and down. And that's really going to help me align myself right through the body. So I'm going to think about shoulders above hips, hips above ankles. And I'm noticing today a certain amount of tension through my neck and my shoulders, probably because I've been at my computer for a while. So I'm just going to invite you all to just take a big stretch up towards the ceiling. And also a yawn. So a yawn is a really great thing in the world of voice. We know it re-energizes, but also it releases tension through the pharynx and around muscles outside and inside of the larynx. So it's a great one. Probably to be enjoyed privately, but just to encourage the release and some new energy. And so just do what you need to do, Chris, up here, just unlocking tension through shoulders, taking a bit of a stretch up through both arms, opening up side and back ribs. And then we're just going to open through both arms, using our out breath to guide us all the way down through the body. Now, if you've a little bit longer, I take this a couple of times. So really breathing in to prepare, out breath, opening up. That's something, that energy is the sort of the state that you need to be bringing in to these situations. So my feet are on the floor, my spine is long, and I want to draw from the world of Buddhist Zen Roshi teacher Joan Halifax, because one of the things she teaches in her practice, which again really grounded in meditation and also very relevant into her work in end-of-life care, is this idea about coming into situations with a strong back. So I want you to think about your strong back now. Think about those 33 vertebrae of the spine. And even as I think about my strong back, instinctively my abdominal muscles immediately activate. Yes? So I want you to invite your belly to be soft. And again, kinesthetic response, a hand on belly might help that. So just give your belly a little bit of a stroke today, a bit of a release. And softening the belly is inviting inspiration to drop in, just as we did in that earlier breathing exercise. And Roshi Joan teaches that strong back enables you to come into a situation with courage, with stability. Yeah, this word anchoring. This idea of expansion, yeah, which we need, yeah, we all need, particularly in terms of resilience. But this soft belly allows us to be open, allows us to be free and flexible and vulnerable, which again isn't a word that we're always using, unfortunately. But again, I would say this is where compassion starts from. So we're coming in with stability, but with an openness and awareness of the other person. How are you feeling in the body, Chris?
Good.
Okay. So coming back to that idea of the lower breath as fuel, as energy, as calm, as confidence, When our voice is calm and confident, it can move freely through tone, through pitch. We can articulate thoughts as words, and we can make other people hear and feel and resonate with what we're saying. A really quick way to warm up your voice regularly is just to sing, yeah, to get into the practice of singing in the shower, despite what your family might be shouting through the bathroom door. And actually singing releases oxytocin. It's a great way to combat stress. If you don't have the time to do that, or it's not appropriate to be doing that in any sort of clinical setting, humming, yeah, again, lock yourself in a room, hum for a few minutes. Not only are you extending the out breath, which again we know is a really fast way to activate parasympathetic nervous system and calm down perceived threat, but you're also going to start releasing those muscles around the larynx. So let's come into a bit of a hum. And I've got one hand on my belly down here just to feel that this is a sound coming from my core. I would recommend taking 2 or 3 minutes just going up and down, sirening up and down through your range, just to release tension, to get those vibrations moving, to connect to your breath. And again, have another big yawn. And come back to this idea of intention. So Chris, can I ask you to come back to that statement, and don't tell us what your intention is this time, but just bringing some of these principles of anchoring your feet, strong back, expansion, soft belly, free voice. Connect to your intention, and can you introduce yourself again to us?
Oh, hi, I'm Chris Farnham. I'm one of the palliative care doctors. Can we just chat for a moment? Would that be all right?
Great, thank you, Chris. Can we pause for a second and do it one more time? But this time, instead of the ums, which again serve a linguistic purpose, yeah, the verbal fillers that give us time to say what we're going to say next. And it may well be that, Chris, the fact that we've got a ticking clock which says we're in our last 2 minutes is the thing that's creating that sort of slight hesitation. But I want you to take your time, and instead of the ums, I want you to replace them with a breath. Yeah, if you need to breathe, breathe. So feel free to use pause rather than punctuating each thought with the initial
Hello. It's so difficult.
So set your intention and try let go of that really a conscious awareness of what you're doing.
Hello, I'm Chris Farnham. I'm one of the palliative care team here. I'd like to have a chat with you, if that's okay.
Oh, that was it, Chris. Yes. Did it feel different to take out the ums?
Well, it was really difficult, but once you'd said it, it wasn't that difficult, because, as you said, that intention was for me to tell them who I was and what I wanted to do. So it was using that concept of the intention, just really focused my mind, actually. Yeah.
Brilliant. So turning your focus onto the other person, right? To understand who are you there to serve? What do they need from you right now? How can you manage your voice, your body, your breath, in order to make sure that they receive your message clearly? Now we are at time, Chris, so I'm going to zoom ahead and just remind ourselves that actually everything that we've looked at so far today, I would call presence, because we're in a 40-minute window. What I wanted to do was to break that down further for you. But again, just reminding ourselves that calming your sympathetic nervous system to approach complex situations with clarity, with confidence, with belief in yourself, in your values, in your abilities, is all about healthy connection. It's about presence. And in terms of what that means clinically, it's starting with connection to yourself before you're then attempting to connect to others. Really briefly, we have created a short check-in just to remind you of those steps. Start with the question around awareness. Yeah, how am I? How are they? Chris, do you want to jump in? I'm sorry.
No, I think it's so right. So with our chap that we're going to go and talk to about the fact that his treatment no longer works, it's making sure, as you say, that we're okay before we go in there. We know what we're going to say. We're calm about what it is. We know that there's going to be other things out there in that conversation that we can't control, about their emotional reaction to what we're saying, about their relationships with each other and how they will impact on their response to us. But our intent is that they know who we are, they know what we're going to tell them, so that there is no more treatment left. But as a doctor or as a nurse, that we're going to be there, we've got all the information for them, and that they hear that and they understand that. And I suppose, Lucinda, do you want to just finish on the concept of influence?
Yes. So ultimately, I think we can sometimes jump into immediately wanting to control other people, right? When there are situations like these. And recognizing, like we've talked you through those steps, that it starts with awareness, this idea of self-management, awareness of self, acceptance of the situation and others, really aligning our thoughts and actions with clear intention so that other people can receive what we're saying in the manner in which we intended. And only then can we start to influence. So that would be the next step. So talking about the different ways in which we can influence people. But I would say it starts with being present, that you're wanting really to create a bridge between you and the other person, just like an actor on stage, a bridge that it reaches out and connects with somebody and allows them to then take a step to connecting to you so they can be truly present with you as well.
Thank you.
Thank you so much for your time today.
Thank you very much, Chris and Lucinda. Fascinating talk. So we have now panelists with us. I have two questions. I don't know if panelists can see. First question is for Dr. Haroon and Dr. Fiona Rawlinson. Can you hear me?
Yes, I can. And
could I request both of you to unmute your mics and take it in turns? I think so. We would like to have Dr. Haroon, your opinion first on this question.
Okay, so this question is from Dr. Atif Waqar from AKU. He talks about collective autonomy and familial autonomy, the concept of that overriding individual autonomy in Eastern societies. And he talks about what happens if the patient has delegated the decision making to the family. So as I said in my talk, if a patient is compos mentis and is able to make their decisions, and they have made a cautious decision of nominating somebody else to make all their health decisions for them, then clearly there is no need for the medical team then to give information to the patient against their desire or against their wishes. They've clearly expressed a wish that they want all discussions to be done with another family member. And in that case, clearly that desire should be followed, and we should make sure that we only speak to the appointed family member. Although in my personal opinion, I know and I've read about this concept of familial autonomy overriding individual autonomy, but my belief on that is very clear, that my contract of care is with the patient. And yes, the family is a very important component, but my primary contract of care is with the patient, and therefore I would always focus on trying to make sure that unless the patient has asked me to speak to someone else, I try and hold all communications with the patient. And I'll let Fiona add to this because it was addressed to the two of us.
Thank you, Haroon, and thank you, everybody. It's great to be part of the session today. I would absolutely echo all that you said. I think as well, we can go back and check, and we can, when we are with the patient, we can see, are they distressed? Actually, do you sense as a healthcare professional that they may want more information? Has that collusion shifted? Actually, do they want information from their family, and their trust in their family is beginning to erode? We can sense all of that from how the patient is, and it's a conversation that harks back to the previous conversations where you established that there is a decision maker, and it can be something simple. Just when we've talked before, you've wanted me to talk to whoever it is about your healthcare decisions. Is that still the case? Or go and check back with the others. is this still how you want to do things? Can I help in any way? So I think remembering, be in a sense, in that way you're respecting everybody, and you're respecting, yes, the patient's autonomy in deciding to delegate, but that might change. And so I think always just, you don't need to check every time you go with the patient. If everything looks straightforward and it seems to be a comfortable conversation that you've had, and you look at the family dynamics, being sure that you can pick up from what you're seeing and what you're hearing in front of you, when, as we've just heard, when that communication is not congruent, when there seems to be a mismatch, that's when you can explore things. So just keeping an open mind, I think, is really important. That's the other thing I would add, really.
Thank you, Fiona. And just the second part of the question is that, would it still be a collusion? So what would be your opinion on this?
I think it is. I think it is. Collusion is that deliberate withholding of truth. So it is collusion, but it might be collusion with the patient's collusion, if you like. It might still be collusion because you're withholding truth. Collusion is not always bad. It's not always bad. It depends what the intent of the collusion is and who is colluding with who, I think. But again, Haroon, do please add.
No, I agree with you. It all, boils down to who is colluding with who. But it's, one important thing, and then the fear of repeating myself is the fact that often in this part of the world we shy behind, or we try to hide behind this fact that there is no evidence, and people in our part of the world don't do that well with bad news and things like that. Well, if there is any evidence, it's to the contrary, and there is no reason for us to assume that people won't cope with this bad news. And often I feel that when you try to shield information, you often end up in a bigger mess than where you started with. Chris, Aoife, if you want to add anything to this discussion.
Yes, Aoife.
From my point of view, yeah, I agree with everything that Haroon and Fiona have said. I was just thinking in my own head of one of the most difficult situations I had with two really well-meaning daughters whose father had an upper GI cancer. And they said to me, you can't tell him he's got brain mets. He had a nervous breakdown when he had his original diagnosis and was hospitalized for 4 months. And we worked really carefully and closely together, myself and the two daughters, to actually talk through exactly what we would say with him. And they came in on it. And ultimately, he didn't have another nervous breakdown. He did know he had brain mets. And his only question was, well, I want to get back in my truck, because he was a long distance lorry driver. But it was, I think, a really lovely experience in so many ways, because we worked so closely together, and they were fully on board before we went to see their father. As you were saying, it's great for relationship building if you can actually reflect that you're really hearing people and you're understanding why they feel this way, why they feel that they should be withholding information. I think you can actually get a much better relationship out of it in the long run, and more trust.
Thank you, Aoife. Chris, do you want to add?
Yeah, so yes, it's all absolutely true what everyone said. And I suppose some of it is language, isn't it? And it's about language, in as much that kind of drawing on the sort of vehicle analogy that Aoife was talking about with the trucks. There's a chap yesterday that, again, family, you can't tell him, you can't tell dad what's happening, he'll just give up. And dad, they said, oh, dad has never wanted to know what's going on. And again, the family were labeled as, oh, they're a nightmare family, we've had real run-ins with them. So people had assumed that this desire for collusion is coming from a bad place, and it's not. It's coming, as you say, it's coming from a position of love, really, and wanting to protect. But then using language that enabled really a discussion that didn't really happen, but did happen. So he's got a vintage car, this chap. And so he said, he started telling me all about his vintage car. So we were sitting there with me thinking my intent was, I've got to tell him, the treatment's not working, we're not going to do anything. And he said, what would you do with my vintage car when things start to go horribly wrong? I said, well, sometimes you can't get the parts of vintage cars. I said, how many miles has it done? He said, oh, it's done 150,000 miles. And I said, yeah. And then sometimes it's just time, isn't it, to sell it? Or maybe, we give it to the scrap broker. And he said, oh, I wouldn't want to give it to the... So we were having a conversation about allowing him to die. And the daughters were their eyes were getting wider and wider and wider. But we got there in the end, but using language that enabled us to have that conversation, for him to know exactly what we were going to do, because that's what we would have done with his vintage car. And he agreed that's what he wanted with his vintage car as well. So I'm not sure if that was collusion or not really, but I kind of felt we'd had that conversation, and as far as he wanted it to go, really.
Great, thank you. So our next question is from Dr. Atif Salim. So if a family does not want patient to know anything about the disease, and the patient is undecided whether he or she wants to know and has been unable to cope with the bad news in the past, what should be done in those situations? So if I can get Aoife to have your opinion on this question, please.
So I think, I guess with this, the patient is king, aren't they? So, well, certainly from an autonomy point of view. So I think you'd spend time, or certainly my approach would be to spend time understanding where the patient had been, what their journey had been before this, how they coped in the past, maybe explore that. And if they were unsure, that's fine, you can park it, because we don't have an absolute right to give information to our patients. And I think that's also one of the things that I highlight, I think we all highlight with the families. We won't impart information that your loved one doesn't want to hear. If they don't want to hear it, we're not going to force that information on them. So if a patient says to me, do you know what, I don't really know if I want to know what's going on for me, I don't know if I can cope with it, he'll give the opportunity to explore what their previous experience has been of coping with difficult information. It would be an opportunity to explore what their fears and their worries are, and maybe what's the worst case scenario for them. And it might be that they decide, you know what, I don't want to know this news today, but leaving that door open, making sure that they can come back to it. I think, again, from a healthcare professional point of view, we're there to treat them. I'm a public servant. I am there to treat my patients. So I'm there to try and help and guide them if I can, if that's what they want. But if, leaving that door open, I'm saying to the patient, we can revisit this conversation. If I felt that they were missing out on a treatment because they didn't know something, that might make me say there might be things that might be affected by us not making a decision, or you not knowing, and that would maybe allow us to explore whether there was a little piece of information that they might want to have so they could make a decision. But I don't think you have to give information, and certainly we don't have the right to, but we absolutely are obliged, I think, to explore what each patient needs and wants.
Great, thank you. In the best interest of time, I have a couple of more questions to go through. And the next one is, and it's a really interesting one. How do you deal with collusion or withholding the truth from other healthcare professionals, especially in context of oncology patients, where your colleague wants to start a new treatment, but you know that patient is dying and has a progressive disease, but the family wants to go ahead as this is their last hope? So can I get Chris to answer this question, please?
Well, I think certainly in the world of palliative care, we get quite used to this, don't we? It's about managing our colleagues, and I think sometimes, oh gosh, I'm going to really alienate lots of people. So our oncology colleagues, and certainly I think as doctors, we're so hardwired, aren't we, to try and treat, and we do, and it's really right that you want an oncologist to treat you. You want an oncologist to be able to find something that's going to work for you. But as you say, sometimes that stops and that doesn't work, and it isn't the right thing. And sometimes it's almost giving them permission to be able to say, no, stop. And I did that yesterday with a woman with very advanced ovarian disease who had got brain metastasis and had progressed through all treatment. And everybody, the oncologist is known as somebody who would, give intra-coffin chemotherapy if he could, I'm sure. And he just wanted to be able, and he had a very good relationship with this woman and just wanted to be able to give her something. And I was able to phone him up and just say, let's stop. Let's stop now. She's dying. Let's allow her to go home. And he said, oh, thank goodness you said that, Chris, because, could you tell the family? And I said, of course I can tell the family. If we've all got our strengths, and yours is the clever stuff around chemotherapy, and I'm here with the patient now. Let me sit down with them. And the patient was really relieved. She was so relieved that she didn't have to continue with a treatment that she was really battling with, and she didn't want to give up to her family. And so taking that away, that decision away from everybody, and just saying, you don't need to do this at the moment. Let's think about getting you home. But it's about those relationships that you have with your colleagues, them trusting you and you trusting them, and then being able to gently challenge. And I'm sure everybody else has that experience as well.
Absolutely, absolutely. We have all come across situations like these. Again, in the best interest of time. So will the participants receive slides? So the talks will be on our symposium page, and people can access this after the symposium, which will be after 7th of November. I thank all the panelists, especially for the colleagues who have joined us from abroad, Chris, Fiona, Aoife, Dr. Harun. It's been a pleasure to have you on the session. Thank you.